So yeah, I'm a health economist. I actually started off life as a pharmacist, so I'm still registered as a pharmacist. So I'm used to explaining this material to people who haven't come from an economics background. Hopefully that will help. But if there's anything that I do say that you still don't get, because we're a small group, just stop me and I'm happy to explain it. The other thing to say is about the title. So because these what is talks are normally about one particular method, and I actually suggested it might be useful for this particular talk to explain carefully the difference between cost effectiveness and cost benefit, because if you look at the literature, the terms are very often inappropriately interchanged. They are completely distinct methods. And really I'm telling you the take-home message for today is to understand that cost effectiveness is not the same as cost benefit, and that's what I'm going to try and explain. And also focus on health, because I'm a health economist, and particularly methods of cost effectiveness analysis are quite particular to healthcare evaluation rather than other methods of public sector evaluation. Okay, so let's get going. So I've been a health economist for a number of years now, 18 years, and when I first started out, it was actually very difficult to explain to people what a health economist actually was. To the extent, if you were, say you're at a party and say, "Oh, I'm a health economist," people would just sort of mumble something and wander off. Now, I'm not saying it's got any better, because the way I can explain to people now what I do is I mention the National Institute for Health and Clinical Excellence, and then people start spitting at me and then wander off, because health economists are viewed as nasty people who stop people getting drugs. So you're starting to see little trite cartoons like this that basically saying quite rude things about health economists. And our favourite newspaper is the Daily Mail, because it always has a good thing to say about us as well. So even to the point of printing your name and saying, write to these people and tell them they're mean. So we're used to having to defend ourselves. But hopefully at the end of today, you'll see we're actually quite useful and quite kind-hearted people, in that we actually want to help people make decisions, and that's what we're about. So I always like to say, what is my challenge as a health economist? Why am I here? What's my reason for being? I'm here as an information provider. I'm not a decision maker. There's a clear distinction between those two concepts, because you'll see that a lot of the methods that I will talk about provide information about how to allocate scarce resources, with the ultimate aim that you're maximising patient benefit given the budget that you have. But what we're not doing is saying you should do this. Now we're using normative methods which would tell a decision maker you should do this, but we're not saying that as individuals. We're just providing the information. There's quite a nuance there, but I think it's an important distinction. So just a little bit about context. I think you come from a health background, so you kind of know that the NHS is a big entity, and now the latest estimate is it takes around 8.2% of the gross domestic product, and that has gone up in real terms. So it used to be hovering around 3-4%, it's now 8%. The NHS budget in England is funded from taxation, so it's funded each year and set each year. So there's an annual allocation for each year, and that's ring-fenced. And so you can look at previous data and see that in 1996-97, the budget allocated was around 33 billion, went up to 96 billion in 2008-09, and the predicted spend for 2012-2013 is 108.9 billion pounds. So yeah, it's going up. Now the NHS remains free at the point of use for everyone resident in the UK. So at the moment, if you look at current figures, that's around 63.2 million people. And from that, you can work out, well, let's have a look at what the average expenditure per person is then. So in 1996, based on those figures, it was around £426. Using 2010 figures, it's gone up to £1,600. But one thing that's happening is that their lifespan is longer. So by definition, you tend to spend more on people because they have more multimorbidities as they get older. Anything else? Yeah, which is what you're looking at with your, yeah. other reasons? How about what's happening in dentistry in terms of treatment options? I'm assuming you've got more at you've got a bigger toolkit than you used to have. Perhaps more interventionist than you used to be. So you're more likely to treat people than you perhaps might have been before. And when you do treat people, you've got perhaps more expensive treatments available to you. So these are all sort of indicative factors. So there's a range of things happening. I've asked this question before, and people have said, "Oh, it's NICE's fault," which I actually think is quite a clever observation, because in some ways that's true. Because by offering guidance and recommendations, NICE is actually saying, well, you should start to use these therapies. These therapies are generally more expensive than existing treatments. So NICE, in some ways, can be the cause. But what it's saying is, well, let's think about whether this is an appropriate increase in expenditure. So I'm not making a judgment that this is wrong. I'm saying this is what is happening. The other interesting aspect, which is a particular interest of Steve Birch's, is that the NHS employs some 1.7 million people, of which 50% are clinically qualified, i.e. they're expensive. They've gone through extensive training programs. And so what we have here is an expensive system which is basically provided by an expensive group of people. And what we want to do is make sure that we're spending the money the best way we possibly can, so we're not wasting resources. So that's the context. So this is where we move on to think about, well, how might we start to think about how we spend these resources effectively? And this is where the concept of efficiency comes in. And efficiency, if you wanted to give it a one-liner definition, is how do we allocate scarce resources so that you maximise benefit? And there are different types of efficiency. One type you might see is allocative. So this is talking about allocation across a whole economy. So what you're trying to do there is think about perhaps not just spending money on health. You might be moving from the education budget to health to social care. So it's really talking about sort of big picture issues. And then there's technical efficiency, and that's really sort of drilling down, so that once you've decided that you've got a healthcare budget, how do you produce a given output, health, for the least cost, or you maximise that output, health, for a given cost. So that's about technical efficiency. And when we get onto the methods of cost effectiveness and cost benefit, you'll see how they address these two different types of efficiency slightly differently. So we've got this concept, efficiency. How do we measure it? We want to know, when do we know we're in an efficient situation? So this all stems from the idea that we're having to make choices. We've got a finite NHS budget, and people are having to make choices about how they allocate the resources within that NHS. And these choices can be made at a number of levels. So they can be made at a government Department of Health level. They can be made at a national level by a body like NICE, which is charged with making decisions and providing guidance. You can have local service commissioners or hospital level providers or dental providers. And then you can have individual clinicians. The reason I've got this slide explicitly here is to show that when we're talking about health economics, what we're generally talking about is informing population level decisions rather than at the individual level. It might be that an individual clinician would take a set of guidance that has had economic evidence to inform it, but it becomes very hard to use these methods explicitly when you have an individual patient in front of you, because the idea is underpinned by this idea about how to allocate resources. You can't allocate much when you've just got one person and you're treating them. And related to that idea is how we make these decisions is this concept of opportunity cost. Have you come across it before? Sorry, I don't know your back. What's your background? Are you an economist? Okay, so you're not an economist. You're not a secret economist hiding. Okay, good though. I have three. They are. So. So I'm assuming, apart from you three, I hope you've heard of this, but opportunity cost is a key and a fundamental underpinning to the methods of economic evaluation that we use. And if you go to Wikipedia, which is, you know, the font of all knowledge, this is what you'll get as a definition. And I remember when I first started in health economics, I didn't have Wikipedia, but I still had this definition. And I thought, actually, I know what all those words mean as individual words. I know what benefit is, I know what a resource is, but I still don't quite get what that means in terms of practical implications. Anyway, so I've got quite an old exercise now. Well, it's a silly game, really. I'm going to give you £30,000, okay? And you've got 3 choices that you can make. So what I'm doing here is, first of all, pointing out the alternative uses for this particular pot of money. I'm only giving you 3. You can't make any other choices. I'll show you why that's relevant to healthcare in a minute. Okay, so those are the 3. Who would pick holiday? Okay, who would pick car? And you'd have pizza. You don't know. Okay, no, that's all right. If you don't know, what you're doing there is you're having difficulty stating your preference. And that's important, because what we assume with these methods is that people have clear preferences. Yeah. So I've given you an alternative here, and you haven't got clear preference. That's an important fundamental underpinning. So let's assume you eventually make up your mind, right? Once you've stated a preference, for the ones who went for the car, why did you go for a car? You're like, oh, that's right, okay. Well, it got flash. Yeah. Probably wouldn't get much for 30 grand now, actually. It wouldn't be that flashy, would it? But so what you've done by picking your car, first of all, you said, I clearly want a car. And then you've said, okay, the benefit that I attach to that choice is that I like cars. So that's why I want a car. But because you've picked a car, you can't have the holiday as well. So you've forgone the benefits of the holiday. Now, they might have been measured in different ways, these benefits for the holiday, but basically you're not going to get them. That's the cost. The fact that you've basically had to pick one thing, but you can't have something else. And so you can obviously see how this would translate into healthcare. So if you had that same budget, you could work out for 30 grand, what would you get? So 57 people could be offered a test, 6 people could have a hip replacement, or 1 person could get Herceptin for breast cancer. How do we make that choice? Who should we pick? When I come back at the end, I'll ask you that question again, and hopefully you might be able to have a better go at that. So economic evaluations are basically the sort of one of a number of methods that health economists have in their sort of methods toolkit, if you like. It's not the only thing that health economists do, but it's the thing that's most transparent and probably most famous, mainly because it's what NICE uses in their decision-making processes. So it's an evaluative framework, and by that I mean you have some way of defining what your research question is in a structured way. So you have some process of healthcare. This might be comparing drugs. So this is where we start to link into the concept of opportunity cost, because you need to have some comparators here. You need to know what your alternatives are, and you need to be able to clearly specify them. So if it's a drug, you might need to say, well, what dose are we using? What's the eligible patient population? So you're very specific in terms of how you define this process. And the number of alternatives you can have, I've put 2 here just to keep it simple, but you can have as many as you like. And ideally, you want your baseline comparator, i.e. starting point, to be current practice. So let's say how things are currently done at the moment, and how might this new intervention that I'm looking at change current practice? And you look at that in terms of the input, so what are the resources and costs, and you attach values to those using unit prices, and then you have some outputs. And this is where we start to delve into the different types of economic evaluation, because the way you measure the outcomes effectively defines what type of economic evaluation you're doing. So if you're looking at clinical effectiveness, you're doing cost effectiveness analysis. If you're looking at a quality adjusted life year, you're doing cost utility analysis. If you're using willingness to pay, you're doing cost benefit. We'll come back to that in a moment. The thing I'm just going to touch on briefly and not really go into too much detail, but it's important to understand, is that there are different ways of collecting the data for economic evaluations. and this is where I've put vehicles for economic evaluation. So one thing you might want to do is design a prospective RCT, and you randomise your population to intervention A or B. And you go out and you prospectively collect resource use and your outcome data for your population over a defined time period. Then you get individual patient level data and you analyse. Yeah. The other approach is to say, okay, well, let's represent this process of care and these care pathways using mathematical modelling. So you have your two interventions, but you model the care pathways. And then you bring together data from numerous sources into this model. So it's a way of assimilating all available data sources. What it also allows you to do is think about the time horizon. So how long you follow people up for. Because if it's for a trial, it's only for the length of the trial. For a model, you might be able to extend it for longer. So the vehicle for your economic evaluation will affect, first of all, the type of analysis you do, and also possibly the usefulness of the results of your analysis. But I can talk more about that if you're interested at the end. So in terms of what should be costed, for any method, the costs that you include are the same, basically. And what you want to try and do is, within reason, take into account all the costs associated with a particular intervention or comparative interventions. But you need to think of a way of sort of clearly defining that, because obviously if you think about that carefully, well, that is actually completely unfeasible. You can't include all costs. You need to have some way of containing what you're looking at. So there are two ways. First of all, you think about the perspective or the viewpoint of the evaluation. So at the broadest level, you would take a societal viewpoint and you would include the costs to everyone. So that would include patients, carers, the NHS, anyone you can think of. That's fine, but sometimes that might not be really what you're interested in, A, and B, it might not be feasible. It might not be practical to collect those data. You do also need to think about, well, why are we using this economic evaluation? Why is it that we're doing it? And if you're thinking about how best to spend a healthcare budget, it might be that the perspective that's most appropriate for you to take is that of the NHS, because that's the budget that you're spending. And that's the stance that NICE takes. It says, look, we're spending the NHS budget, so we only include the cost of the NHS. And at the moment, explicitly excludes costs of patients, for example. Now, there's ongoing debate, and NICE is revisiting its methods about whether or not it should include other costs or broaden the perspective. But at the moment, it's very firmly in the camp NHS, social services, because they're now included as part of the NHS, and that's the viewpoint we take. If you are a decision maker, for example, working within a hospital or wanting to set up a drug formulary, it might be that it's only relevant to take the hospital perspective, because you're not interested in how the costs would incur on primary care, for example. So this viewpoint is very important to define. It'll affect what costs you include, but it will also affect the usefulness of the results that you get. Related to that is the time horizon, and I've already alluded to this when I've talked about using trial-based versus model-based evaluations. Because what you want to understand is how the costs change over time, depending on how long you follow up your patient. So if you say you're looking at an intervention that was treating someone in the emergency department for a heart attack. So one time horizon you might choose is 1 year, and you'd look at the subsequent costs that patient incurs over a year. And they might be fine for a year, they might not have another heart attack in a year. So that's that particular horizon. You extend it to 10 years, and then they might have another heart attack in 3 years' time, which is subsequently treated. So if you incur the costs in that 3-year time horizon, they will be higher. So you'll get a different set of costs included compared to the 1-year perspective, 1-year time horizon. NICE likes you to take a lifetime horizon. So you have a starting age relevant to your patient population, and you follow them up until death. And that is why they encourage the use of models, because that, in theory, they allow you to do that. But obviously there's some extrapolation of data from your current data sources, so you have to make assumptions sometimes when you're taking that horizon. Right, so costs, that's the last, I'm not going to say any more about costs. The reason cost effectiveness analysis and cost benefit analysis is different is because of how we define the benefit that we measure. And the benefits, outcomes and consequences all mean the same thing to a health economist. There's no, you can interchange those terminologies, there's no difference. The important thing to note though is that we're talking about measuring the effect on the patient, not on the person providing the service. And you might say, well, that's obvious, but when you actually come to design your evaluation, that can actually become quite difficult. So because I come from a pharmacy background, and so pharmacists often want to provide a service to patients, and they start to think about what outcomes they might want to include in their evaluation. And they start to say things, well, it saves the pharmacist time. Well, that shouldn't be costed as an outcome. That is actually that's an item of resource. It's not a benefit because it doesn't actually affect the outcome on the patient. The fact that the pharmacist has saved some time, patients don't care about that. So that's how you have to sort of bring yourself back and think, what happens to the patient and how can we measure that? And clearly cost is not an outcome measure, even though you'll see many research proposals written when they write down, they go outcomes to be measured, and they always put resource use costs under that heading, always. But it isn't. It's incorrect, but we have to live with it because we live in a clinical trial environment, so that's the terminology people like to use. So we've already talked about that. So let's think, and we've already talked about the different methods of economic evaluation. So one method you might see mentioned in the literature quite a lot is cost minimisation analysis. And that's when you assume that the outcome between the interventions that you're comparing is exactly the same. It has to be based on robust evidence, and you have to be very clear that there's actually no difference at all. Now, there's quite a large literature now that basically says CMA is dead. So effectively, health economists don't like to use cost minimisation because there's very rarely a situation where you can prove the outcomes are the same, first of all. And secondly, without getting into too much jargon, it's assuming a frequentist approach to statistics, in that you're using something like a p-value to say whether there's any difference in outcome between your two interventions. Well, that has a lot of loaded assumptions within it, and it also takes away the uncertainty in some of the data that you might have. So for numerous reasons, if you end up doing a CMA and try and get it published and a health economist reviews it, you will struggle. So they'll say, no, you shouldn't be doing that anymore. Cost effectiveness and cost utility, those two terms are interchanged, and they're used slightly differently from this side of the pond to the other side of the pond. So Americans use the term cost utility, cost effectiveness different to UK or mainland Europe. You'll see in a minute that effectively they are the same, so they're grouped together, they are the same evaluative framework. Cost benefit is something completely different, and so that's what I'm going to do next. First of all, I'm going to explain what cost effectiveness is, and then I'm going to explain what cost benefit is with some examples. Okie dokie. So cost effectiveness. Both of these methods, cost effectiveness and cost benefit, are underpinned by economic theory, and the big theories for these evaluative frameworks is called welfare economics. Okay, and then within that you have two views of the world. One view of the world is the extra welfarist perspective, and this is what provides the theoretical foundation for cost effectiveness analysis. Cost effectiveness analysis is rooted in this theory. Now, I could spend an whole hour explaining what the extra welfarist perspective is and probably end up confusing you, because sometimes I'm not entirely clear myself, and neither are most health economists, because the boundaries between an extra welfarist and a welfarist view of the world is very blurry. Do you guys agree with that? It's not just me being thick, right? Okay. So it blurs. So the way that it's been sort of implemented in practice is that basically what we're doing here, we're taking a social decision maker's view which is deciding how best to spend the healthcare budget. And so therefore, because it's a healthcare budget, the benefit that we want to maximise is health. So this then becomes this question of reaching technical efficiency. You've dedicated your budget to healthcare, you want to maximise health. Okay. So given that, that's what you want to maximise, by definition, you need some instrument to describe and value this nebulous concept called health. Yeah? How are we going to value health? And this is important because if you look at how economic evaluation has been used in practice, most economic evaluations now are either cost effectiveness or cost utility analysis. And I've just a useful resource for people who aren't very familiar with methods of economic evaluation is this database. Because what it's available through the Centre of Reviews and Dissemination at York. And what it does, it's a repository for structured critical appraisals of published economic evaluations. So it identifies any published economic evaluation. First of all, says whether it really is an economic evaluation. And then a health economist will have produced a structured abstract, which is quite long, but it goes through each of the components. So it's not actually a repository for the published paper, it's a critique of the published paper. So if you and it will tell you whether if it's sort of good, bad or indifferent in terms of study quality, so it's quite useful. The only challenge with it is that there's obviously a time lag between when they publish the paper and the health economist getting around to writing the critical appraisal, because they're quite busy people, so there's always a bit of a lag. But if you identify a published paper that's in the literature and you go online and there isn't actually a structured abstract, you can actually contact these guys and say, I want one, and they'll do one for you. So let's take a sort of think about what we mean, because we're talking about cost effectiveness analysis. So if you come from a clinical background, there's a very clear definition in your head perhaps what effectiveness is. And the first thing I think is to differentiate it from a related concept, which is efficacy. So if you're looking at clinical trial data on a new drug in terms of providing evidence for regulatory approval, what you tend to see there is efficacy data, because it's the drug being used in very tightly controlled patient populations, and it will be the drug compared to a placebo. What you want in terms of effectiveness data is your drug compared to current practice, which might be no treatment, but that no treatment is not the same as placebo. So being very specific here what we mean about effectiveness. And then it should be a measure that you can basically count. So it's natural units. So it might be something like the number of cases you successfully diagnose or treat. Or you might look at the impact on mortality. So how many additional years of life do you get? So that's an effectiveness measure. And you can also use clinical indicators like sort of pain-free days or improvements in C-reactive protein levels, for example, if you're looking at a treatment for rheumatoid arthritis. So you can get this type of information from RCTs or meta-analyses. That's why we want to think about this concept of health, because most modern medicine improves the quality of someone's life, not the quantity. Yeah, we can keep people alive for a little bit longer, but we're all going to die. You know, we know that. But what you want to do is basically live for as long as you can, as high a quality as you can. And using these clinical effectiveness measures implies that changes in these will directly link to patients' health-related quality of life. And in some instances that might be true, but quite often it's not. But when you start to think of, though, what is the definition of quality of life, it actually becomes quite challenging, because there are many aspects to quality of life, broadly, and there are, even if you only focus on health-related quality of life, there are still many, many facets that you could include. So there's a whole literature out there where people have developed quality of life measures, and these can be broadly divided into ones that are generic and ones that are disease-specific. So if you're looking at generic ones, this is where you get measures of health status like the EQ5D. Have any of you come across this? Yeah. Okay, so the EQ5D is something that was designed back in the 1990s to provide a structured way to value a changing health. So you can see it's got 5 domains there, and each of those 5 domains have 3 levels in this example. There is actually a newer version of the EQ5D which has 5 levels now, and also they've developed ones for use in children with vision bolt-ons. So there's different versions. It takes away the generic nature, you might argue, but this is the one that NICE recommends that we should be using. But you have to do so. What you have to do this is obviously think about what we're trying to measure here. We're trying to measure sort of changes in benefit for a particular population. So you would give this people this instrument at baseline, and they would check how they feel at baseline, and then you pick some time horizon that's relevant to you. So it might be 3 months, six months, and then a year, and you repeat the measures. And so then you'd end up with a profile of scores for your EQ5D. It's great, but it's still really not very useful to us, because everyone who fills in this questionnaire will have a different view about what these particular domains mean to them. So what we have to do is convert this onto a metric scale that allows us to compare between individuals. So this is where you get this utility concept from, which anchors the scale of utility from 0 being death and 1 being perfect health. And we have structured methods to move from the scores there onto a utility scale. And this is where you come across concepts like time trade-off and standard gamble. Have you come across those? No. I won't get, you don't really, basically, that little arrow there, something magic in between happens, and I can't explain what that is, but it's a level of detail you don't really need to know. What you need to understand is that we do move from these instruments to using a linear scale, where we assume that 1 is twice as big as 0.5. And then that's what we use to actually generate our QALY. So we have some construct where we're looking at the amount of time that we're going to live, and then what our utility value is. So assume that I've got 5 years left, and then I get run over by a bus. So that's the end of me in 5 years' time. I'm feeling a bit ropey at the minute, so my utility value is not 1. It's around 0.85. So if you worked out how many QALYs I'd have left, it's just the area under that curve. So obviously, if it's a rectangle, it's pretty easy. People's utility values go up and down. So that's where you get methods of integration to work out your area under curves to actually calculate what your QALYs are. And you look at differences between your interventions. So then you plot that on a plane. So because we've got our costs for each of our interventions and our QALYs for each of the interventions, we can look at whether, if you're looking at A minus B, so you have to say what your comparator is, you can see where that would fall on this particular picture. So you've got different levels here. So if you had an intervention there, so drug A costs £15,000 more than drug B, and you get fewer QALYs, what would you do with that particular drug? Bin it, yeah? Right. So that's all we do. You just move around those quadrants, thinking about where you're falling in terms of increased costs and increased QALYs. Now, if you look at what happens to NICE, most of the interventions say, okay, we cost a little bit more, but hey, we're really giving you some extra benefit here. And this is where you get your magic cost per QALY from, because you're looking at the difference in costs divided by your difference in QALYs. Right. So let's go back to our choice of 57 genetic tests, 6 hit replacements, or Herceptin. Which one should we pick? I've said there is I've given you evidence to make that decision. I haven't really. I've given you some evidence, because you still have to think about whether we should recommend the particular intervention that we've chosen. And there are 2 things that you might need to think about. First of all, what is the quality of the evaluation? So that's what NICE does. So as part of its appraisal process, it's appraising the quality of the evidence. Yes, it's bringing it together in a structured assessment package, but the committee is actually saying, how good is these data? And so there needs to be a consistent approach to inform the decision making, because you want it to be the same across all interventions. And there might be uncertainty in the technical details and the value inputs, and that's exactly what the NICE committee discusses, whether they believe the evidence in front of them. And also they will use critical appraisal tools, and that's what the reference case is. It actually says this is the evidence we actually want to see to support this particular intervention. There are other critical appraisal tools out there, but the NICE has one specifically for its decision-making processes. The next thing to understand is, well, what's this threshold for cost effectiveness? So if you've got an intervention that's £31,000 per QALY, using NICE criteria, you would probably say no to it. It's not as simple as having a very clear cut-off there, because it is very much intertwined with the quality of the evidence as well. So if you're really sure it's 31, you might actually be more likely to say yes, and it's something that you're very uncertain about it being 31. So there are subjective value judgments that go into this decision as well. So that method, those processes that I've just used, really feed into all of the NICE methods guides, be it for public health, diagnostics, technology appraisals. That's what they're using. Cost benefit, slightly different. Uses the welfareist perspective. It assumes that what you're trying to do is you're taking the utility of individuals, and utility in cost-benefit analysis means a slightly different thing to utility in the context of cost-effectiveness analysis. But what you're trying to capture here is some measure of desirability or preference for a good or a service. And as you've already said, there are very few examples of CBA in practice, and these guys produced a systematic review which summarised where we were back in 2007. And I would say it's perhaps not changed very much now in terms of how many are published out there. So, given what we want to do is think about expressing benefits as a monetary value. That's what cost-benefit analysis is. And so the underpinning method is called the contingent valuation method. All that means is that you're setting up some hypothetical market, because there's no actual market for the good that we're looking at. It's healthcare. So it's some hypothetical market. That's the contingent bit. And you're basically giving people a scenario, and you're getting them to value what they think the benefits are. So that's why a contingent valuation comes from. And what you're trying to do is develop a method so you can elicit people's willingness to pay or perhaps accept to avoid a particular illness. And what that is assumed to represent is you elicit the willingness to pay from everyone in your population, and you add it up, and overall it's assumed to represent the total value the society thinks is attached to that particular intervention. And so this monetary value could be the value to avoid an illness or obtain the benefits of a treatment. And it could include health benefits, but it could also include non-health benefits. Non-health benefits might be something like, if you had a genetic test, it might be the information you get from that test. That's a non-health benefit, so it's information itself. Or it could be a process benefit. So if you were providing a dental service, it might be how much people value having an experienced dentist versus a dental technician to do a piece of work. So they value some aspect of the process. So just thought I'd show you very quickly an example of how we've tried to use this method at Manchester. So I'm working with research called Martin Eden, and me and Martin are looking at a particular intervention which is centred around an inherited condition that makes people go blind. And the idea is that you can offer people a genetic service which will provide them with information about their likelihood of passing the disease on to family members, or think about how their disease might progress over time. So the actual service comprises genetic counselling, but also genetic testing as well. But not everybody can be tested. They're developing new next generation sequencing methods to test people, and so what they want to try and understand is what are the benefits of offering this test to more people, because potentially that's going to be available when you use next generation compared with current methods. So that's a bit of the context, and basically what we're doing is you present people with a scenario where you explain what it is you're trying to get them to understand and value. And you also explain to them the context of the decision, that it's within the NHS. Okay, the NHS is still free, but think about this like you're actually based in somewhere like the United States where you do have to pay. So you kind of set the scene. Generally do these, you can do them postally, but they work better if you do them face-to-face because you can explain things with people. Now, with this study, we also collected qualitative data alongside as well to understand how people were completing the questions, and that's what Caroline's doing for her PhD. We're using another stated preference method, and she's going to be collecting qualitative data alongside these as well, because it's obviously very, they can be quite challenging for people to complete, and you want to make sure you're measuring what you think you're measuring. Anyway, so we actually ran this in a relatively small sample in terms of a quantitative study, but quite a large sample if you think of it in qualitative terms. So we had 52 people. About half of them had experience of this disease we were interested in, and so some of them were blind. So what we had to do is first of all, we printed those scenarios off in large font. Or we made sure it was readable with their e-reader devices, so that they sort of speak the scenarios to them. And the other population were people. They were members of university staff, but we used them to see, well, what would happen if you gave these scenarios to people if they didn't understand anything about the condition. And then we basically asked them to state their willingness to pay for two examples. First of all, where you just had genetic counselling alone, and then secondly, genetic counselling and testing. So what you do is you first of all say, would you have counselling? And they say yes. And then you take them through an iterative bidding process. So you start off at a value and say, would you pay this? They go yes, no. Then you increase it, decrease it appropriately. And you basically hone down onto their maximum willingness to pay value. And what we've got on here is just shows the distribution of the values that we got. The main thing to take home really is that on the right hand side where you're adding in testing, people were willing to pay a little bit more, so there was some additional value seen to adding in testing to counselling. Now what we need to do now is go back, use the qualitative data to see if we've designed the survey well enough, because this was a pilot study, and then field it in a larger sample so we can go out and actually elicit proper values. Whether we actually ever get around to doing that will be another matter, but that's the plan. So the theory in using these methods is that you have a slightly different decision rule to what you would use for cost effectiveness. So cost effectiveness analysis, we were creating this incremental outcome change. It's reminding me, that's what Steve Birch, say him ISAs are brilliant and he'll hit you. He really will. He's published, so I think he wrote a paper. I think he said the ISA was information created to evade reality. I think that's what he actually redefined the ISA as. So he really doesn't like ISAs. Okay, just to wind him up. Anyway, but in CBA, what we want to do is use this concept that you can compensate people, and the people are the gainers or the losers from the intervention. So this is what a potential Pareto improvement means. So the gainers can financially compensate the losers and still be better off, and that's the decision rule that you try to make. So what you do is you use willingness to pay to elicit a monetary benefit. That allows you to compare across both within and across public sectors. And so if you're looking outside of health, the evaluative method used is cost benefit. So if you're looking at education, they use cost benefit. It's only health that they don't. And the decision rule then is you introduce a technology or an intervention that has positive benefits, i.e. where the benefit you've calculated is bigger than the cost of the intervention. But in the UK context, very few examples. And this is all economists thinking that CBA is a bad idea. Some think that there's no reason why health should be any different. But there are substantial methodological and ethical concerns with using willingness to pay, and it's well published and written down in many different ways. But what's happening at the moment is that current policymakers are taking a very pragmatic, social decision maker's perspective on how to make decisions. It's a healthcare budget, so let's maximise health. Let's not try and measure all these other non-health and process things. Let's just stick with measuring what we think we can measure and do that consistently for all interventions. So that's the end really. Just to conclude, why use economic evaluation? Well, hopefully you've seen it's a useful input into decision making. It's just another source of evidence, though. It's not the only source. So you need to have it alongside epidemiological data, systematic reviews, clinical trials. It's part of a package and can inform decision making at different levels. Model-based cost effectiveness analysis really has become a key part of HTA and appraisal, particularly by NICE. Whether you use CEA or CBA, at the moment, all health economists would use CEA probably. And I wouldn't get struck down by saying that. But there are some of us who are still trying to use CBA, particularly for some interventions where if you're just trying to measure health gain, you're just not going to get it. And genetic testing is the obvious example. So we're still, trying to push back the methods and trying to use them. But being very aware that if you do that, you're not using a consistent approach across all technologies because they are completely different and they have different theories.